Good evening to all. Today my topic is upfront surgery in T3N0 carcinoma larynx. Today we are discussing T3. There is we all know tumor limited to larynx with the vocal cord fixation and or invasion of the paraglottic space or erosion of the inner cortex of the thyrocartilage. So T3N0, it goes to stage 3. So today we are discussing on all the parameters like laryngeal preservation approach, and on this approach are we meeting our overall survival and disease free survival also. So what is laryngeal preservation approach? So since last 2 decades our focus shifted towards the functional, means larynx preservation approach. So what is the aim to achieve? So complete tumor response, preserving the laryngeal function, and better overall survival and disease free survival, means recurrence free survival. So there are 2 approaches, surgical and non-surgical options. So since these last 2 randomized control trials, these non-surgical organ preservation came into the picture before 2 decades. So the first was the Veteran Affairs VA trial, and I'll go in very briefly. Stage 3 and stage 4 laryngeal squamous carcinoma was there, and larynx preservation was 64% in that study. While salvage laryngectomy is required in the stage 3 was 29% and in stage 4 was 44%. Large proportion of the recurrence occur locally, most of them within the 1 year, and so hinting a scenario where the laryngeal preservation may not work, means salvage laryngectomy is more required in higher in the glottic primaries, fixed vocal cords, cartilage invasion and large volume disease. And the second landmark trial was RTOG 9111, where there were 3 arms: induction chemotherapy followed by radiotherapy, then chemoradiation and radiation alone. So the long term results were 2-year result and the 10-year results, but both showing that the concurrent chemoradiation laryngeal preservation was good, 84%, but the late toxicities 81% in induction chemo and 82% were in concurrent CTRT group. Salvage laryngectomies following RTOG 9111, so 129 patients required the salvage laryngectomies, out of those included loco-regional control following the salvage laryngectomies, around 74% in concurrent chemo group and induction group, while 90% for radiation alone. This was after salvage laryngectomy. And what was the drawback of 9111? So there were no surgical arm in this study, and primary endpoint was laryngectomy free survival, not the overall survival or disease free survival. And factors associated with the severe late toxicities after the concurrent chemoradiation for locally advanced head and neck cancer, this was same RTOG analysis. It was 43% of patients had late toxicities. Out of those, all included the patients. In that grade 3 and 4 toxicities, Rice tube dependency and aspirated pneumonia and death also. So outcome of the salvage laryngectomies following the organ preservation therapy. So now we will talk only on T3 with the fixed cord. Induction was in 9111 was 82, CTRT arm was 82 and RT was 76. So approximately 30%, including patients of the induction and CTRT arm, it was 30% required who required the salvage laryngectomies. Will directly compare with the transoral laryngeal microsurgery. The paper was 2 decades before Steiner. At the same time, it was in 2003 and this was in 2001. But the salvage laryngectomy is required in T2B. It was 13%, while in T3 with fixed cord 14.3%. So the direct comparison was 30% in RTOG arm, RTOG study, and 14% after transoral laryngeal microsurgery. and overall disease specific survival was 87% in transoral laryngeal microsurgery. So the direct comparative study for now will directly go on the overall survival and disease free survival. That was the laryngeal preservation survival. So this was the very famous Hoffman study in 2002, where they have seen that the specific analysis for the T3N0 M0 glottic squamous cell carcinoma, and the hypothesis was the decreased survival identified for the T3N0 M0 glottic squamous cell carcinoma correlates with the increased use of the non-surgical treatment. That was the hypothesis for the Hoffman, and we can see here it was 1,58,426 patients from the National Cancer Database from USA, and out of that 51% were the glottic T3 carcinomas. So 5-year survival treated with the surgery alone was 69%, and radiation alone was the 47.9%. This was the retrospective analysis of the National Cancer Database by the Hoffman. So how safe non-surgical organ preservation? So there are multiple studies, but I quoted the studies where the end size is like more than 1 lakh. So in Chen et al., TL significantly associated with the increased likelihood of survival compared with RT or CTRT. Then Hoffman, we have seen the decreasing survival among the patients with the laryngeal cancer while using non-surgical treatment. And in the Mizono et al. Study, the better survival was observed with the treatment for the local surgery. So now the new trend is vocal cord fixity, regain the movement or the fixation of the movement after the treatment of T3 larynx. So this was the paper by Dr. Vishal Rao, and they have noticed that the 52% complete regain of the vocal cord mobility after CRT, while 48% remain the fixed vocal cord after completion of CRT. And these 48% patients, they have higher chances of recurrence also, and the local recurrence is higher in the patients who had fixed vocal cord after full completion of CRT, and they developed aspiration pneumonia and dysfunctional larynx also. So this another one study, return of the vocal cord movement, an independent predictor of response to non-surgical management of the laryngeal cancer. So this is another organ preserving transoral laryngeal microsurgery. This is specific study for the T3 laryngeal carcinomas. So they have seen that the median follow-up period was 57 months, and the 5-year organ preservation and local control rate for all the patients, for all the T3 patients, it was 87% and 71%. And overall survival, recurrence free survival and disease specific survival were very higher, 64.4%, 63 and 83%. And this is must read one review article by Petra Ambrose. So in that also 5-year recurrence free survival rate in T3 glottic carcinoma after transoral laryngeal microsurgery was 71%. So this paper, this is review article by Dr. Anil De Cruz sir, and this is must read, that we get to know that variable endpoints of the landmark articles were totally different. So every landmark article, the endpoint was not the overall survival and disease free survival. So, the landmark article endpoints were primary endpoint, secondary endpoint were totally different. So again, main thing is patient selections for the this T3 laryngeal cancer, whether to do transoral laryngeal surgeries or whether to give CRT or whether to do for total laryngectomy or near total laryngectomy. Then disease categorization to select an approach, and translating evidence based articles into the clinical practice. So I'll conclude this thing. T3 carcinoma larynx, surgical management followed by adjuvant treatment has better overall survival and recurrence free survival, comparable voice outcome and low rate of for dysphagia and lymphedema in surgical arm. For transoral laryngeal microsurgery, choosing the right patient for the better outcome, and patients with the deeply infiltrated T3 glottic cancers, fixed cords, cartilage erosions and the bulky disease do well with the surgery followed by adjuvant approach. This is a vertical partial laryngectomy patient and the voice of this patient. Total gaya. Okay, fine. So he has vertical partial laryngectomy for the T3 laryngeal cancer. Thank you.
Thank you, sir. And now for the radiation side, I'd like to call upon Dr. Kinjal Jani, sir.
Good evening, everyone. First of all, I'd like to thank Priyanka, Hirak and Viraj. Viraj I'm not seeing here, but they have invited me for this debate and for this conference. And I have seen the program. It's a fantastic program covering everything in oncology. It's a very nice debate, whether to give RT or surgery in T3N0. With this, first of all, what I'll do is I'll go through the guidelines. But before I go through my presentation, I would like to thank Dr. Somesh Chandra, who is not here. But we were in Udaipur a couple of weeks back. We had a conference of head and neck only in Udaipur, and Dr. Somesh was given a talk on role of surgery in CA larynx, including everything from T1 to T4. And I was very impressed with his talk. After the presentation, myself and Dr. Dakshesh is sitting there. Me and Dakshesh were talking to Somesh sir. How many surgeries you have done for T3? We specifically asked because my debate was on T3. So both of us asked. Dakshesh said I have only done 2 in last so many years. Somesh sir did not even answer. So how many people are competent enough to do open partial laryngectomy? Nirav would disagree with me. Nirav is the moderator for this session. He would give the expert comments, Nirav Trivedi. He does a lot of fantastic surgeries. Even for a T4 which is going very high up, he does a lot of skull-based surgeries also. So he would have done more. But Dakshesh very honestly said, I have only done 2 in last so many years. So how many surgeries you do in T3, like a open partial laryngectomy or an endoscopic partial laryngectomy? So now comes the thing, what guidelines is. So I'll talk about guidelines, and as Priyank has very well mentioned all the papers. I'll not even quote a single paper. I'll just put one paper which is a meta-analysis. I'll just quote that. So I'll talk about the NCCN guidelines. What is T3? So larynx is divided into supraglottis, glottis and subglottis. So if you're talking supraglottis, it is tumor limited to larynx with vocal cord fixation or invading postcricoid, pre-epiglottic space, para-epiglottic space and inner cortex of thyroid cartilage. While Priyanka was giving his talk, I was talking to Nirav. Nirav said, T3 માં કોઈ દિવસ તો N0 આવતું જ નથી. જો supraglottis હોય, T3 હોય, so it is going to be N1 N2. It is not going to be N0. So now come to larynx. Now come to glottis. What is glottis T3? Tumor limited to larynx with cord fixation and or invasion of paraglottic space and inner cartilage invasion. Inner cartilage invasion was not there few years back when we started practice. So me, Dakshesh and Nirav, when we started practice, it was not there as a T3, it was a T4A. Now it is in T3. So that has come up in T3. And for subglottis, again, exactly the same, what is there in glottis. So these are T3s. So we are talking about only T3s. I'll go to any tumor, which is, where we can do a larynx preserving surgery. So what does the guideline say for a T1, T2, N0 or for a selected group of T3, N0? What is the treatment option? As you can very well see here, it is RT, or a partial laryngectomy which can be endoscopic or open, which he has presented very well. You can do that. But when you do surgery, you need to know that if you're going to see any adverse pathological features later on, you don't need to add more morbidity to the patient. If you can cure a T3N0 which is amenable to surgery, a selected group of T3, you can cure it with only radiotherapy, not even adding chemotherapy. Why would you go for a surgery? Because you will need to give radiotherapy afterwards. So this is what the guideline says. So he is also right that surgery definitely is there for a T3N0. Similarly, for a T3 which is amenable to only total laryngectomy, because there are bad T3s also. There are not all T3s are not good. There are bad T3s, and we come across a lot of patients. So what we do is we do concurrent CTRT, we go for a surgery followed by radiotherapy, or we do induction chemotherapy. The medical oncologist, I'm not saying too many medical oncologists here, but medical oncologists will be very happy to take these patients upfront. Why? Because induction chemotherapy has taught us from hypopharynx and oropharynx that give induction chemotherapy, see if the patient responds or not. And if the patient responds, you can go for a curative CTRT and avoid the surgery. If the patient is not responding, then you definitely go for surgery. And as rightly mentioned by Priyank, morbidity increases whenever you give induction chemotherapy. So we have to take everything with a pinch of salt. Everything looking good on the paper is not good for that particular patient. We see a different patient, Americans see different patients. So everything is different. So these are the options for a T3. This is for glottic cancer. After induction, if there is a complete response, you go for radiotherapy. Partial response, again you have the option of going for RT or CTRT, and if it is less than PR, you go for surgery, or then you see after doing the surgery whether you need to give adjuvant treatment or not. If you talk about supraglottis, again in supraglottis there is a definite role for endoscopic resection. You can do a robotic surgery, and you can get rid of the disease, like if it is in epiglottis or A fold, or you have the option of definitive RT plus or minus CT if other factors are there. And similarly, for who require total laryngectomy, again the option for supraglottis is exactly the same what is there for glottis, either concurrent CTRT, RT alone if CT is not tolerable, or you go for laryngectomy followed by whatever the report comes. You can plan for the adjuvant treatment accordingly, or go for an induction chemotherapy. Now, what to do? Like we have discussed, okay, T3 guidelines has said this, but guideline is an American guideline. What do we do? What we should do in a T3N0? We have to talk. I and my surgeon always talk for a T3 lesion specifically for the same. As I rightly said couple of slides back, they are not same. A T3, early T3 having only a glottic disease with a paraglottic extension is absolutely curable with only radiotherapy, not even chemotherapy is required. That is called a T3. Or involving the inner cortex of thyroid may require induction chemo followed by CTRT, or he might do a surgery. So lot of things are there in T3. T3 is a gray zone. T1, T2 we are very sure surgery karna hai, laser karna hai ya RT karna hai. T4 we are very sure you operate and then we'll give adjuvant. But for a T3 it's a gray zone. It's a gray zone for everyone, and it's a heterogeneous group. As I just said, it's a heterogeneous group. There are a lot of things which we have to think before we decide the treatment. Patient's age, patient's general condition, what is patient's preference, and the size of the tumor. That all matters. That all matters before we decide whether we jump onto one treatment or not. So what are the important things before planning for treatment for a T3N0 or any larynx? A good Hopkins examination or a stroboscopy is very important. You can pick up a very early lesion on a strobo, which you may not pick up on Hopkins. So either you do a Hopkins or you do a strobo. Again, the surgeons do it, I don't do it, but it is the first thing which has to be done. Then the DLE and a biopsy. Generally, when we get a patient from an ENT surgeon, we just get it with the biopsy report. But if it has come as a fresh patient to you with a horses of voice, you should do a DLE and do a biopsy. MRI neck with contrast is very important, because whenever you want to know about the cartilage, whenever you want to know about the paraglottic extension, as I was saying, the vocal cord may not be fixed. It may be partial fixed or not fixed, but having paraglottic extension comes into T3. but that patient can be cured with radiotherapy alone. So MRI gives a very good idea about paraglottic extension and cartilage invasion. PET scan, again, the role of PET scan for larynx, it's a debatable issue, so I'll not go into details. There are a lot of surgeons and a lot of radiation oncologists who feel that we should not do a PET scan, and there are a lot of people who feel that we should do a PET scan for any malignancy. So it's absolutely a debatable issue, but again, not in our context, so I'll not go into detail. So when you go for a surgery, you have options. You can go for an endoscopic partial laryngectomy, open partial laryngectomy, or a total laryngectomy. Expertise is very important. So what I, Dakshesh and Sumesh sir discussed was that only, that we need to have that expertise to do a partial laryngectomy and preserve the voice. Even after doing a total laryngectomy, when we put a valve, patient can speak so well. So even for a T4, if it's a T4, patient has to go for a surgery, he goes for a surgery, we put TEP, and patient is speaking so well. When they come for radiotherapy, they are talking to us with, keeping the finger on the tracheostomy. So expertise is very important when you talk about surgery. And we have to think about the complications. So whenever the complication of radiotherapy comes up, we need to think about the complication of surgery also. The voice quality goes down. There may be edema. You might need to add radiotherapy to that surgery, and the complication will definitely increase. So you have to keep everything in mind when you think about surgery. Now if you talk about radiotherapy, what we were always told by the surgeons whenever we had a debate or anything, we were told that आप bilateral radiotherapy देते हो, सब जगह को जला देते हो, और पेशेंट हमारे पास कॉम्प्लिकेशन लेके आता है, उसका E-fold edematous होता है, और we need to put a temporary tracheostomy for that to heal. But now with the newer modality like IMRTs and VMATs or proton which has come up now, we can do a very focused radiotherapy. We can do hypofractionation. So for a T1, T2, it has been proven, it is in the NCCN guidelines there, we don't need to give 33 radiations. We can finish it in 20-25 radiations, between 20 to 25. So that has been proven. We can do, for a T3, we can do differential dosage. So for a primary tumor, we give high dose, and for the prophylactic neck, we give less dose. Complications, again, yes, I do understand. Edema to the AE-fold is the bad side effect of radiotherapy, and many patients suffer a lot for a long time, and we might have to put a temporary tracheostomy. But again, you need an expertise to plan your treatment in such a way for a particular patient so that the complication can be avoided. And now the role of induction chemotherapy has come up, so that we can downstage the tumor and then think whether we go for surgery or we go for chemoradiation. We as a radiation oncologist should not depend on salvage laryngectomy if we feel that CTRT cannot cure it. So if we feel that this patient is not curable with CTRT, it has to be operated first, because anyways adjuvant RT is going to take care of the microscopic mets. So for a lesion which you are seeing here, if for a lesion like this, if this lesion comes to us in a tumor ward, I would refer to my surgeon, this or this lesion. We would do laser. It's a T1 lesion, by the way. And a lesion like this comes, we would definitely go for chemoradiation. We do a partial larynx radiation like this. So earlier we used to do it like this, and now we do it like a solid single side vocal cord also. I don't personally do it, but there are a lot of people doing it. And this is called a differential dosage, where you give a high dose to the larynx area, and the neck nodes you can give lesser dose, so you can finish off the treatment faster. And this was the paper I was going to quote, the comparisons. So this was a study done in Switzerland. They have taken 122 papers, and then they have given a conclusion. For a T1, T2, you decide according to either surgery or radiation is exactly the same. For the disease, this is what we are talking about. For a T3, T4 tumor, you have to decide whether you do a partial laryngectomy or you go for a non-surgical modality. As I already heard a thing, I'll not go into detail, I'll not read everything, I'll just go to the last slide. Viraj is not here, but Viraj is a fan of AI, ChatGPT. So Viraj taught me what is ChatGPT. So I asked ChatGPT what to do for a T3N0 CA larynx, and this is what I got. For a T3N0 larynx cancer, both surgery and radiotherapy can achieve similar survival rates, but radiation therapy often allows for larynx preservation and voice conservation, while surgery can lead to voice loss or require more extensive procedures. The best treatment approach depends on individual factors like tumor location, patient health, and functional goals. So that is what I got from AI. Again, if Viraj was there, I would have been happy. So at the end, my take-home message is it has to be discussed in MDT. and that was the theme of this conference, that MDT is very important whenever you treat any cancer patients, but specifically for a T3N0, MDT is a must. For a T1, T2, a surgeon sees, and if he wants to do a laser, absolutely go ahead. We don't need to see that patient, but for a T3N0, definitely we need to discuss. Now comes the role of swallowing expert. We have Akshar. Akshar is here. Akshar goes to all the hospitals. All people in Ahmedabad know Akshar. Akshar's role plays a very important role in swallowing, because whether you do a surgery or you do radiotherapy, patient will have problems with swallowing. So his role comes before we start the treatment. You know, if you're planning for a surgery, immediately you rehabilitate that patient, or if you're planning for radiotherapy, we should involve a swallowing expert beforehand so that the patient does not suffer and his or her nutrition is maintained. And just like other sites in head and neck, the role of NSCT is on rise for larynx, which was not there earlier, but we must use it with cautious. We cannot use it for all patients. We have to select our patient who requires NSCT. We should not do it for all patients. And this is very coming up thing. I don't want to give any comments, but a role of immunotherapy is coming up in a big way in head and neck. So people go for neoadjuvant immunotherapy for oropharynx, oral cavity, hypopharynx and larynx also. And there are trials now. So that is something which is coming up in a big way. With this, I would just end, and thank you so much.
Thanks a lot, sir. And now for the expert comment, I'd like to call Dr. Nirav Trivedi, sir. Sir, over to you, sir.
Very good presentation, Priyanka and Kinjal. Thank you very much. As both of them suggested, my personal opinion is that in last few decades, if we see, the biggest achievement that as a group we have done is incorporating multiple treatment approaches as an MDT in management of patients. So I think every single protocol, every single approach has a stay in managing patients, may it be surgery, radiotherapy, chemotherapy. So instead of fighting that one is better than other, the smart thing is to pick the right approach for right type of patient. That's my personal philosophy. Every T3 larynx cannot be cured by radiotherapy, as you said, and every T3 larynx doesn't need a surgery, as you suggested. So we have to find a balance, and the smart thing is to predict which is going to be more successful in this particular. That's called personalized therapy, but we only associate personalized therapy with genetic mutations and all. But in clinical practice, I'm pretty sure that all of us do triage based on our experience and certain factors. So T3 larynx, as I mentioned to Kinjal, my experiences, most of them do come with large nodes. So again, your treatment approach will vary. If it's T3N1, young fit patient, you want to preserve voice and larynx both, and you will probably err on kind of non-surgical organ position. But similar patient, if it's a 75-year-old gentleman, frail, probably won't tolerate CTRT, definitely not salvage surgery, will probably err more towards approaching it with a total laryngectomy or a conservative laryngectomy. But again, old patient, total laryngectomy with a TEP would be a better approach. Similarly, T3, large nodes, you don't want to give CTRT because if the node doesn't respond, the salvage is very difficult and all. So again, my personal take is that pick and choose your patient with all the data available as well as your clinical experience, and which modality will suit that patient best. So